You're listening to the Lung Lab podcast made possible by the Open Source Imaging Consortium. Here's your host, Elizabeth Estes.
In this episode, we speak with Dr. Lisa Lancaster, who has spent her career working with those living with fibrosing and other rare lung diseases and their caregivers and their families. She has understood and has shared with me over many years the burden that the patients face. And so I was really looking forward to sitting down and talking with her because it is why OSIC exists, to help make progress for these patients and their families. Dr. Lisa Lancaster. So to now, this is so much fun. You know what the best part of these conventions in a lot of ways and these all of these education experiences that we have, but it's also seeing old friends at places like 100%.
this. 100%.
I mean,
absolutely.
Longtime friends, not old.
Right.
We're not old.
Not
yet.
No.
Not yet.
Well,
yeah, Dr. Lisa Lancaster, my friend who I've known for a long time, one of the bright stars in the space. So tell everybody what you do, who you are, where you work, all of those things.
So I am a pulmonologist and specialize in interstitial lung disease. I've been doing that for 25 years. I did my training initially at Vanderbilt, residency, fellowship, and ended up staying on as faculty. And my first year in faculty was handed the opportunity to be principal investigator for the gamma interferon study, really one of the very first international multi-center clinical trials in IPF. And then it grew from there. Our program grew from 2 physicians to ultimately a total of 6 with multiple nurse practitioners, coordinators, and now 85 clinical trials later and 2 approved drugs.
85?
And now with positive phase 3 study within the last year, it's really an exciting space to be in. And I've evolved from purely local clinical trials. I still see patients at Vanderbilt. I still have a half-day clinic, but I'm also Chief Medical Officer for Endeavor Biometrics. And we're presently have a hedgehog inhibitor in clinical trials in a phase 2B study.
Oh, God, you're such an underachiever. All right. So first of all, I've been to your clinic. I've been to your offices. I've met your amazing nurse practitioners. I've had dinner with one of them. A team that is passionate about these patients and these people living with this disease and their families and their caregivers. I've been down there. I've seen it. And really that, I think, knowing them and knowing you, that's really what I saw when I came drives you every day.
Yeah, that's the bottom line. You've got to be invested in the mission. Yeah. And that's what it's all about. We're all here for the patients. And I think being patient first focused at the ground level in patient care, in clinical trials, and at a company who's studying pulmonary fibrosis and therapies in pulmonary fibrosis, keeping the patient focused first is the critical element of the mission.
So let's talk about this. So for people who don't know what this journey is like for them, right? And you see them every day, you talk to them. How does someone get to you at Vanderbilt? What path have they gone through to get there? And then let's talk about the journey that they go through living with pulmonary fibrosis.
Yeah, it's a long journey, actually, just to get to the point of diagnosis. Most patients have seen their primary care provider a few times before.
Seen them with what? Cough? Breathlessness?
Cough, shortness of breath. Usually those are the main things that bring in, and that's very nonspecific symptoms. Yeah. And so it can be confused with a lot of different things: asthma, COPD, heart disease, like heart failure, ischemia even. And so those workups ensue at the primary care level, and that usually takes a few visits.
Right.
Appropriately so. Statistically, those are the things that are more common in this age group of patients with pulmonary fibrosis that generally are age 50 or older.
Right.
So those things are ruled out, and then ultimately usually imaging is done, chest x-ray usually followed by CT, or maybe just a chest x-ray at that point, or the physician hears crackles on exam, and they've ruled out cardiac causes or other causes, and then refer the patient to a pulmonologist, who then usually gets a high-resolution chest CT, that critical CT that's got a focus on the lung parenchyma and can really dive into the detail of what's going on in the lungs. And then they'll look at not just the pattern on the CT, but really take a good, thorough history of chronologically, what kind of symptoms occur? When did the cough occur? When did the shortness of breath occur? Are you limited in any daily activities? And go through a full rheumatologic review of systems, as that can cause lung disease. And then assess for any comorbidities of interstitial lung disease or pulmonary fibrosis, like reflux, obstructive sleep apnea,
Right.
As well, and pulmonary hypertension. And go through that questioning, go through a good, thorough exposure history from work, occupational, to pets, animals, just living in environment,
Birds.
mold, birds. Yes,
Yeah.
exactly. And those things, if you can see, that's really a huge compilation. I haven't gotten to the physical exam
I was just
yet.
going to say, whoa.
That's a lot to go through.
Right.
And so, in general, most pulmonologists who are private and in the community only have 30 minutes to try to hit this and do as well as they can in that amount of time.
And how many of those pulmonologists that aren't experts in interstitial lung disease, and they've been trained on it, at least the GP probably never has, right?
Right, usually not so much. And then that trickles down to our nurse practitioners and PAs who may have not had specialty training in that. The physical exam helps us mainly rule out other diseases like autoimmune disease, so we can look for changes in the hand. So you really have to be pretty savvy, and maybe have seen a lot of patients in your career or in your training with this. So it really takes a village of support, and that's where the specialty ILD centers can really help out, because they see the volume. They're used to asking these questions of patients, having perhaps a little bit more time to spend with patients, and not just make the diagnosis, but also discuss treatment and other supportive care.
When I tell people the project I'm working on, usually they look at me blankly, but then pulmonary fibrosis now, is it genetic? There's what, 10, 15%?
Yeah.
Is what we think?
Yeah, even up to 20%. There are some experts that will even take that number as high as 50%.
Really?
Yeah, but usually it's in 15, 20% or so range. We're learning more.
Yeah.
And now we have a handful of genes. We're learning more and more that may be connected. We have specialty centers, like at my center at Vanderbilt, National Jewish, that are working together exactly to try to tease out what those genetic nuances are.
But mostly we believe it's environmental or epigenetic, right? I mean, that's...
Yeah, probably a little bit of everything. There's probably some underlay of genetics that put people at risk.
Yeah.
And then exposure
Yeah.
that plays into that, perhaps comorbidities that are aggravating that, other disease processes like connective tissue disease or inflammatory bowel disease that may have interstitial lung disease as a component. Those all things kind of play into teasing that out and understanding the diagnosis and then how best to manage it. But the average patient, from earlier data from Greg Cosgrove and his team, right, showed that it takes 1 to 2 years for most patients to make the diagnosis, and I believe it was something like 38% had 2 misdiagnoses and 50% had at least 1 misdiagnosis. It's not easy. It takes a village. It's not like you can draw just blood work and say, aha, this is what you've got.
You know, you mentioned, there's so many ways we can go here, but you mentioned the stethoscope and the listening. I've been told that pulmonary fibrosis sounds very different in a stethoscope than other diseases, that it sounds like Velcro. Is that true?
That's true. We describe it as Velcro crackles. Some people would describe it as even just rubbing your hair together. Oh. Kind of a dry, crackly sound at the end of inspiration, the sound of stiff alveoli kind of popping open.
And again, I'm not a doctor. I don't even play one on TV. I didn't stay at a Motel 6 last night, but I'm going to try to do this. Normally starts in the bottom.
You know, the start part is the curious part, because what we're seeing is the 30,000-foot view.
Right.
With
usually people who have been diagnosed later and they've had it for a while.
Yeah, where do we pick it up? Because there's a huge preclinical portion, but we certainly see in pulmonary fibrosis worse disease at the bases than in the apices. So there's that basal or predominance of the disease.
So what about, and then I want to come back to talk about the patient journey, right? Because there's some things that have bothered me from the beginning that I've started for them. But what about this, the new thought that a lot of the long haul COVID people may have pulmonary fibrosis. So do you subscribe to that theory? We don't know yet if it'll be progressive, if it's not progressive. What have you seen at Vanderbilt from the long haul COVID to pulmonary fibrosis?
So I think in the very beginning, we had scary news from abroad.
Yeah.
And we certainly were fearful that this was going to be an epidemic
Of pulmonary fibrosis.
Of pulmonary fibrosis as a result. And it really hasn't panned out.
Yeah.
Can people get post-inflammatory pulmonary fibrosis when they have bad viral infections from anything? Yes, that can happen. And how it plays out, it seems to me as far as progressive and few and far between, I personally have a lot of questions. Are we just catching it after the COVID and it's been
they had it there for a while, right? It was dormant,
We just don't know, but those cases I think are, at least in my experience, are few and far between than a large majority of cases post-COVID.
And now we know that smoking is a risk factor, right? And we've been talking with a lot of people today about the ILA and lung cancer screening, which OSIC is, as you know, going into and bringing more data in. We talked to a physician in a city in the U.S. recently who said that he had 4 patients under the age of 40. And I said, what? And I said, why? And he said, vaping and some other things. And I said, wow, that's crazy. Have you seen a rise in younger patients yet from anything like that, from those risk factors?
Yeah. Personally in my clinic, I tend to have an older population. Yeah. So, but certainly in spots around the country, there have been case reports of higher incidence of that, even ARDS, and concern about vaping, the vehicle that what is being vaped or the tobacco is in or nicotine is in. Yeah. So
don't do it.
Yeah, don't do it. We don't. The lungs are very delicate organ, and the last thing you want to do, it's not like you want to go and inhale pollution, right?
Yeah, right.
So keep what's going in your lungs as clean and pure as possible, and avoid extraneous substances inhaled. Certainly when you don't exactly know what's in it. Right.
Yeah, right. So, I've said this many times. This is the part, and I think I've said it to you before. I can't imagine seeing a patient that you have to deliver news to and a family with a spouse or whomever with them, that they're going to have a disease that is a deadly disease, right? And having them say, well, doc, what does this mean? Like, what's my life going to be and how long do I have? And you having to say, we don't know. Because we don't know. Not because it's any slight on you, because we don't have enough information to understand the progressors from the non-progressors. We don't know yet, or we don't know enough yet to know that. I mean, I can't imagine being in that position.
Yeah, it's it can be intense.
Yeah.
And it's certainly, I think with time, you have your story of discussion with patients. I think at the same time, it's a challenge to deliver the information, but not destroy hope.
Right, yeah.
Because there's a lot that we don't know. We can't necessarily predict what next year or the next year will look like. People have variable courses of disease. And that's a little bit of a double-edged sword.
Right.
We also now have the hope of therapies that do slow disease progression.
Right.
And how that plays into their survival down the road. We have a lot of drug candidates that are out there that look very promising. So I think there are a lot of reasons for hope where prior to 2014, we just didn't have it other than lung transplantation.
Right.
So I think we've come a long way, but we still have a long way to go.
Right.
But balancing that hope is important. And I think the other piece of this that I think is critical, that when you have a patient with a disease that doesn't necessarily have a cure, and there are a lot of diseases that don't have cures. We can't cure diabetes. We can't cure heart disease.
But you can live with it longer, multiple myeloma. You can live longer.
That's right. But we certainly don't want to destroy hope, and we don't want to say, I don't have anything to offer.
That's right, because we do.
Because we do.
Right.
And and there not just drugs, but we've got pulmonary rehab.
Right.
We've got treatment of comorbidities. We've got therapies for that, including pulmonary hypertension now, or PH-ILD. We've got evaluation for lung transplant, and those numbers and age and comorbidity allowances are being expanded. But we don't want patients to feel alone, and they need to feel like their physician is on the journey with them. That is the most important thing.
So let's talk about hope. So what, you're here among some of the brightest pulmonologists in the world at the European Respiratory Society. What have you seen that gives you like, wow, there's some things coming, or there's some really new things that make me even have more hope than I had before? Obviously, you're working on a new drug. There are people working on new different modalities of drugs. But what do you see that's exciting?
I think that's the biggest thing, is a number.
Right.
The number of companies, the number of drug candidates that are out there with different mechanisms of action is a sign of research and interest in the disease. And I think that is priceless.
Yeah.
Because even if those particular candidates don't manifest into something, then you learn something in the process, and you are a little bit further along with each negative study. We would not be where we are if it hadn't been so many negative studies in the past, because what they do is we teach us about the disease, the prognosis, biomarkers, ways to diagnose the disease earlier, perhaps other pathways that we can abrogate that could be future candidates for.
Yeah, I mean, that's a hard, pardon the pun, hard pill to swallow for a lot of patients, because they're putting hope on these things and then they don't work. But there is something positive about the negative trials, because we know then where to start from there instead of starting over from scratch. It's hard to explain that, and it's hard because, I'm not living with that disease, but I do think we say this all the time. So many people are so worried about ground truth. We have to start somewhere in order to find that ground truth. And a lot of times we take a couple steps backwards in order to take 3 or 4 forward.
Yeah, I think that's true. And in that sense, if you really think about it, because you're learning from every single trial, there really is no negative study.
Yeah, right, exactly.
Because you come out with positives. Whether the primary endpoint is hit or not, you come out with positives in learning in every single study. So nothing that anybody invested interest or time in really is a waste in the end.
So you have been a supporter of OSIC from the very beginning. You have been a big support for me personally to like, come on, Elizabeth, you can do this, and cheering me on. And you're, there's not a lot of women in this space. There get more. Thankfully, there's more physicians and more pulmonologists that are being women. But and you sat through the OSIC member meeting on Saturday and got to see some cool things. If you were to give OSIC a piece of advice, which I know that, and I ask you all the time for this, but I'm asking you publicly.
Yeah.
If you were to give us a piece of advice, what do we need to do more? What do we need to do different? How do we need to be better?
Yeah, no. One is keep doing what you're doing. I think working to better understand, promote quantitative HRCT, how that can tell us more about disease processes like interstitial lung disease, from the point of diagnosis to markers of disease progression.
Yeah.
And how those markers of disease progression could potentially be modified by drug therapy. How we can get to a point where high resolution quantitative CT imaging can potentially be utilized with all its just vast amount of information as a primary regulatory endpoint would be fabulous.
Yeah.
Because it just is it's 4-dimensional in comparison to
an FVC.
Right?
Yeah.
And with each year, with each conference, which are major ones every 3 to 6 months or so,
right.
I think we're learning more and we're getting there. And OSIC's collection of CT scans really gives the foundation for that to occur and happen, and source of research data that can answer questions that we haven't been able to ask in the past because we didn't have the resources and the data.
Yeah, I mean, I think the key for us is working with smart people like you, listening to you, because you really are the voice of the patients to us. I mean, we talk to the patients, we go to different patient meetings, we hear from them, but I remember one of the first times we sat down and you talked about what was going on at Vanderbilt, and I came down there and I saw it and I witnessed it myself and people waiting in the lobby. And, I think we have to continue to make sure we dialogue with the people on the ground who are actually speaking to the patients. And yes, we have a lot of machine learners doing really cool things, as you saw on Saturday. Right. A lot of new technologies coming out to try to help make progress in the disease. But at the bottom line, it's coming back to you as a physician who's saying, what are the patients saying? What do we need to do? And like I keep saying, we've all collectively done a lot since 2014. We got to go faster.
Right. And how do we expand that beyond urban areas and ILD academic centers to more rural regions? How can we help the local physician at not just the pulmonary level, but the primary care level? Make these diagnoses earlier and get patients to specialists.
Yeah, I mean, we were talking about this with with Sebastian Schmidt from Siemens. Like we're bringing in these lung cancer screens, right? We know there's there's risk factors that are shared, the smoking, right, the age group. So these lung cancer screenings, I think they have a really big opportunity for us to find people sooner, to diagnose it sooner, to get them to these places sooner. I'm hopeful anyway.
Absolutely, and lung cancer screening tends to pick up ILD.
Right.
And our radiologists find that all the time, and providers end up referring patients to us that way. There can be just occult findings on other imaging. Abdominal CT scans, even that catch the base of the lungs, usually can be a source for that. So awareness. And it really takes a village. Awareness in the primary care, awareness in our mid-level providers, nurse practitioners, PAs, awareness in pulmonologists and radiologists who are even looking at not the chest, but the abdomen, to really find these patients and having pathways within their own system to get them to the right spot to make the diagnosis.
All right, so I've asked everybody, last question. Then I can let you off the spot. Crystal ball.
Yeah.
We're sitting 10 years from now, not looking much older. We wish.
That's all right.
We wish.
There'll be things by then that could do.
Yeah, good point. 10 years from now, we're sitting at a conference and we're looking back, what's happened? Where are we? Mm-hmm. What has been done for these patients in 10 years?
I think our holy grail is really looking for that therapy that has a chance of disease reversal.
Right. Because right now the therapies that are out there are thankfully we have a couple, two and a half, as I've been saying, almost 3. Right. And they slow down progression, but they don't reverse it.
Right. Yeah. And then coupled with that are therapies that are safe, therapies that are tolerable, easy to take. Maybe we don't have to take them so frequently, or maybe they're inhaled and that's very easy to do once a day or something like that. So things that are patient-centered and patient-focused that not just improve or lessen their disease, but improve patients' symptoms and quality of life and lessen that symptom burden for patients. Yeah, that's where I would hope we would be.
Right now we have a deadly disease. The first goal would be let's make it a chronic disease, right? And then let's make no disease. That's the hope, and that's the goal.
That's right. We want something to melt it away.
Dr. Lancaster, you're wonderful as always. I said earlier, there's such a passionate group of physicians in this space. I hope the patients know, not just their own doctor, but so many of them are coming together and they're just passionate about the patients and passionate about making progress in this disease. And you've always been that for me. So thank you.
Oh, thank you. I feel lucky to be a part of the group of my colleagues and honored to be a doctor to my patients. So thanks.
All right. Have fun back in Vanderbilt.
Oh, thank you. Thank you.
Thanks for listening to the Lung Lab podcast from OSIC. Share this episode of the Lung Lab and subscribe to the show wherever you get your podcasts. The Lung Lab podcast is produced by Bloodstream Media. Learn more at www.bloodstreammedia.com.